Dr. Mary D. Willis is a postdoctoral research scholar at Oregon State University. Her work examines the influence of environmental hazards on reproductive health. She specifically focuses how complex industrial exposures affect local communities and how epidemiology can inform effective policy decisions to improve population health. Please welcome Dr. Willis.
So today I'm going to walk you through our new work on associations between residential proximity to oil and gas drilling and term birth weight. This work was recently published in Environmental Health Perspectives earlier this year, and you can access the full paper using the link at the bottom of this slide. To ensure that we're all on the same page, I'll briefly summarize some of the oil and gas terminology that's relevant to this talk. This is definitely an oversimplification, but it's worth it for this brief presentation. There are two distinct methods for resource extraction: conventional and unconventional. Conventional extraction involves drilling straight down into the ground into a pocket of oil or gas, similar to extracting the filling out of a jelly donut. In contrast, unconventional extraction, colloquially more often known as fracking, requires drilling straight down, then curving the borehole to be parallel to the surface. High volume, high pressure fluids are often pumped into the ground to extract oil or gas from microscopic cracks, similar to extracting the filling from a tiramisu or a layered cake. While most of the media and community concern focuses specifically on unconventional natural gas drilling, there is substantial conventional drilling happening around the country. In the map on the right, I show the spatial distribution of drilling by drilling type in Texas. This means how the resource is being removed from the ground. Blue dots are conventional drilling and purple dots are unconventional drilling. It's worth noting that some communities are exposed to both unconventional and conventional drilling simultaneously. And then in the graph on the left, I show some of the annual volumes of oil and gas production within Texas. Since the 1980s, the state has seen an immense increase in the volume of natural gas resources being extracted, shown in orange. However, oil drilling is still occurring across, as shown in blue. In this study, we focus on the full scope of the active oil and gas industry. In Texas, 4.5 million of its residents live within 1.6 kilometers or 1 mile of at least one oil or gas drilling site. In this state, setback distances between a drilling site and a home can be as small as 60 meters in some areas. On the left, you can see an aerial view of an extraction area west of Houston. Each brown spot on this image is an individual drilling site, not a house. And on the right, you can see a rendering of what this immense drilling activity looks like underground, where each pipe is a separate site. This industry has the potential to impact a community along multiple dimensions of their daily lives. First, there are economic considerations, such as increased employment from the new industry in the region. Second, there are significant demographic changes from the influx of new people into the area. And third, there are environmental impacts of this industry, such as increased air pollution from the burning of excess natural gas or water pollution from fracking fluids. This combination of exposures can create beneficial or adverse public health impacts, depending on what subset of the exposures a given area receives. For instance, some previous studies have found adverse infant health outcomes, such as decreased birth weight, among residents living in close proximity to these extraction sites. While other similarly designed studies have found some evidence of protective effects, like reduced preterm birth among residents living in close proximity. In order to fully understand the environmental health impacts of this industry, we need to use study designs that account for the economic and demographic changes that are simultaneously occurring to isolate the effect of environmental pollution on population health. We specifically designed this study to address a few complaints about epidemiologic work, not taking into account the massive sociodemographic changes that come with a boomtown. This study then specifically aims to quantify the influence of environmental exposures to oil and gas drilling during pregnancy on term birth weight. To accomplish this objective, we leverage a population-based retrospective birth cohort from the Vital Statistics database in Texas, where we have every birth in the state from 1996 through 2009. Each maternal residence at delivery is geocoded to the address level, meaning that we have the exact point where this mother reported living at the end of her pregnancy. These records contain detailed demographic information on the mother-infant dyad, as well as some clinical information on birth risk factors. Since we have address-level data, we're also able to integrate relevant spatial data on the neighborhoods to better understand the community context in which each mother resides. Within this vital statistics cohort, we assign maternal exposure based on simple residential proximity to sites. As Dr. Diesel already noted, sometimes a complicated exposure metric is not what a policymaker actually wants. We're really thinking about informing setback distances of this study, So we argue that a simple proximity metric is appropriate. A recent drilling-related environmental pollution model showed that oil, air, and water pollution from the drilling site itself is concentrated within 1 kilometer of the drilling site and should dissipate to background levels by about 3 kilometers away. So we're using this far distance at 3 to 10 kilometers as a comparison group. This exposure is limited to extraction sites with specific characteristics for their primary resource, drilling type, and spud date. Spud date being the date that drilling began at a specific location. Using the vital statistics data, we examined term birth weight as reported on the birth certificate. And within these births, we restrict our sample to singleton pregnancies whose mothers reside within 10 kilometers of active or future drilling activity, which reduces dissimilarities between these communities. You'll notice that the included spud dates span the time period before and after the birth data is contained. This choice serves 2 distinct purposes to improve our exposure estimates. First, by including spud dates after our vital statistics cohort ends, we're able to build a better counterfactual population of women who have the potential to be exposed to this industry, but are not actually exposed during their pregnancy. Second, we reduce the potential for exposure misclassification by including drilling sites that started before our vital statistics cohort began. These drilling sites can be active for up to 20 years after the spud date, and not including them would misclassify many women as unexposed. We aim to use this combination of design choices to reduce the unmeasured confounding in our final models. Our implementation of the difference in differences study design, therefore, has spatial and temporal components. In the difference in differences model, we're examining the interaction between living within 1 kilometer of where a drilling site is or will be and living within 10 kilometers before and after drilling. In its simplest form, this study design is literally 2 sets of subtraction. We first calculate the difference in birth weight between living near a future drilling site A and living near an active drilling site C. We then calculate the difference between living far from a future drilling site B and living far from an active drilling site D, which represents the counterfactual control group. We then subtract the results of the pre-post far group from the pre-post near group to find the risk estimates of drilling on infant health without the potential economic gains or sociodemographic changes infiltrating our risk estimates. In order for the study design to work, we need to figure out 2 distinct issues. Are there changes in population composition in response to drilling booms? And are there similar trends over time in our exposed and control groups? This technique overall allows us to be more confident that the confounding from spatial and temporal changes are not infiltrating our final risk estimates. To understand this question, we then examine our data in a few different ways. First, we examine population demographics in each of the 4 groups that comprise the difference in differences term. Second, we look at the outcome trends over time within these difference in differences groups to identify any key time periods that may be an external source of confounding. Third, we run linear regression models with robust standard errors using a variety of covariates. Note that only a small subset of the models we have run are presented here, so feel free to ask about additional results in the question session when we get to that. This graph depicts the hypothesized relationships among the covariates in our models. Right off the bat, keep in mind that a 2-dimensional conceptual diagram cannot fully show the complex space-time relationships that the difference in differences analysis considers. Model 1 is just the unadjusted association between our exposure and outcome of interest. This risk estimate will be the simple subtraction that I discussed in the previous slide. Model 2 incorporates some maternal sociodemographic characteristics and clinical risk factors. And Model 3 takes into account some neighborhood contextual factors and spatial variation that we were worried about. Models without a red or blue box around it are examined in sensitivity analyses, and we can discuss that if anyone is interested. So here is a subset of the descriptive statistics that we derived to examine changes in population. You can see that the total number of births in our analysis is roughly 2.3 million. We vary the exposure group in each subsequent analysis for the 1 to 2 kilometer and 2 to 3 kilometer groups, but the 3 to 10 kilometer comparison group remains the same in all analyses. The difference in differences term, as I've mentioned, is the result of subtracting pre-drilling versus post-drilling in the 3 to 10 kilometer group, shown in green, from the pre-drilling versus post-drilling in the 0 to 1 kilometer group, shown in yellow. You can see that a pre-post analysis on the group that lives within 0 to 1 kilometer of drilling would yield a risk estimate of a 30-gram decrease in term birth weight. However, a pre-post analysis on the group that lives 3 to 10 kilometers from drilling shows a 14-gram decrease in term birth weight, Yet this group should not be exposed to the environmental pollution from drilling. When we remove the secular trend from our risk estimate, we find a 16-gram decrease in term birth weight, which is the difference in differences term presented here. This means a standard pre-post analysis would have yielded a risk estimate that's far larger than what is likely attributable to drilling-related environmental exposures. Overall, you'll also notice that many of our demographic characteristics are very similar between groups in the difference in differences term, except for the proportion of Black non-Hispanic women, Hispanic women, and the proportion attaining a high school education. Here, we simply plot the mean term birth weight by year within each group of the difference in differences term. These trends are roughly parallel over time, except for an anomaly in the 2008 to 2009 period among the near and unexposed group. We looked into this peculiarity and we can't find any empirical reason for it. However, we do hypothesize that the Great Recession may have differentially impacted places that were supposed to have drilling come into the area, but did not actually receive it. For what it's worth, I ran models with and without these birth years, and it did not impact our results. These tables depict the results from the 3 model iterations, and I'll walk you through them. Within 1 kilometer of drilling, we find that there is a 16.3 gram reduction in term birth weight in the unadjusted model. However, once we account for spatial variation and neighborhood characteristics, this association is further attenuated to a 7.3 gram reduction in term birth weight. Surprisingly, these associations for term birth weight persist out to the 1 to 2 and 2 to 3 kilometer groups with no real signs of an exposure response relationship. Within this study, then, those results I just presented, there are some key limitations to consider when interpreting the results. Since we used a vital statistics database, our exposure assignment is predicated on maternal address at delivery. We know that many women move addresses during pregnancy, but this information is not captured in a large administrative database. Residential proximity metrics also do limit our ability to find causative exposures, as Dr. Diesel already discussed. We supplement some of this issue with information on estimated exposure gradients and measured outdoor air pollution, but these hypotheses are not easily testable in our current framework. Furthermore, these vital statistics databases only capture live births, so we do miss any pregnancies that did not result in a live birth, nor do we see couples suffering from infertility, both of which are community concerns that we acknowledge are there. Finally, we acknowledge that there is substantial potential for unmeasured confounding at the individual, neighborhood, and regional levels. While difference in differences study designs do reduce the magnitude of this issue relative to some traditional epidemiologic setups, we simply cannot measure everything that may be relevant to our exposure outcome relationship. So overall, we find that residing within 3 kilometers of oil and gas drilling sites during pregnancy was associated with a small reduction in term birth weight. Therefore, these results do largely agree with previous work in epidemiology and economics, though our magnitude of association is much smaller. We also observed no clear or consistent differences in this association by type of extraction or resource in supplemental models. And then in other supplemental models, we do find some evidence of inequitable distributions of exposure among infants born to Hispanic women, women with less educational attainment, women living in cities, where we find a larger magnitude of association. So that leaves us with the elephant in the room. What's next? Here you can see the span of oil and gas development in the United States. And there are published studies that demonstrate adverse infant health outcomes with closer proximity to oil and gas development in 5 of these states so far. There's some bit of inconsistency among these studies, but the overall adverse association is an ongoing theme. But there's certainly more research to be done. Most of the priorities that I'd advocate for fall on the exposure assessment side. We still do not understand the specific exposure mechanisms that may be involved here. Could it be air pollution, water contamination, noise pollution, etc.? There's some amazing work that Dr. Diesel highlighted that has expanded this part of the field, and I'm sure we'll be hearing about it at this conference in the future. We also need to understand the interactions between social stressors that come from this industry and how they interact with the environmental pollution. And then finally, there's also just a need to collect health data that covers populations that reside close to oil and gas development, but also temporally align with these complex exposures. However, as Dr. Diesel did eloquently put it in a commentary about this study, and I thoroughly agree, the current evidence supports the urgent need for policies to mitigate oil and gas related impacts. A somewhat small body of scientific literature on birth outcomes has still made it pretty clear that there's a consistent association between living closer to oil and gas development sites and adverse birth outcomes. This concludes my presentation. I'd like to acknowledge the awesome co-author team of economists and epidemiologists on this project, Elaine Hill and Andrew Bossel at the University of Rochester, as well as Molly Kyle, Susan Carrozza, and Perry Heistad at Oregon State University. Our various data providers and funders are also listed here. And with that, I'd like to thank you all for virtually attending this presentation, and I'm excited for your questions and comments at the end of this session.